First off, Michael, I want to thank you and the IOM team for the opportunity to be part of this and being part of this important initiative. This is such an important initiative, and boy, the time is right. And Peter, for your support and your inspired leadership on helping make this real, I want to thank you. The workshop was an extraordinary couple of days because it brought together a lot of people who lived this and whose work has been long-standing in trying to put together important measures, find ways to make those measures lead us toward a better health system. And it brought them together and asked them to see if they could at least examine a framework for commonality. That is such a critical initiative. And I want to run through some of the themes that came out of it and give an example of why it's so important. So that really is my charge today. When the group was first formed and the planning committee came together, these are some of the broad objectives that they had. The idea was to examine a vision for core health metrics. And this, of course, could be a ranging discussion, but there were excellent discussions around this. Certainly learn deeply from the existing efforts and see where the potential for commonality and a core set of metrics could exist. Ideally, then, move into some real work, identifying metrics that reliably measure care, costs, and health. And this is where the discussions got exciting, they got interesting, challenging, people looking across and exploring each other's belief systems, frankly, if you really think about it. And then finally describe some of the implementation strategies for these measures. And I'm going to, at the end, talk a little bit about this because this is so important and it really goes to the heart of why this initiative is so timely. Let me just summarize some of the themes that came out and that are included in the report. Ideally, if you could move toward common measures, they're going to emphasize issues that are most important to improving the triple aims. That's pivotal. They have to meet that challenge of supporting improvement of health, costs, and care delivery. They also support improvement in the health services and the payment strategies that help drive those services, aligning payment with the goals of health services. Core metrics should also reduce the burden of measurement. And boy, did that theme come out over and over. That's a starting point for everybody. Reduce that burden, it's so important, and something a lot of time was spent discussing. Also, core measures should really be derived with input from the range of perspectives and stakeholders that have experience and also have an interest in seeing this help move us toward a continuously learning health system. In addition, core measures should really help us be able to examine variation across the range of health services. And in Vermont, and I think other places around the country, not just healthcare, but health and human services. We really need to broaden the vision. Can we come to core measures that help accomplish that? They also should support coordinated and effective health services, both for individuals and populations. Can you come to a set of measures that help meet these needs? And then ideally, if you have common measures, and this is so timely, they will guide the creation of a robust digital infrastructure. Right now, so much is going into building out our digital infrastructure across America, and without a roadmap, without that GPS signal, without some guiding set of core metrics, there's a chance we won't be able to exchange the information we want, a chance that we won't be able to compare variation across settings. So this is timely, and a lot of investment is going into the digital infrastructure across the country. Most importantly, and I want to emphasize, and again thank the IOM team and Peter for this, the enthusiasm and the optimism and the interest. People got together, and with all the natural tendencies of thinking about the initiatives they're involved in and thinking about where they are in their work, there was optimism and interest for setting aside some of those interests and really looking at the potential for common measures. This really is pivotal. The mood, the tone, the investment is right. So, one of the challenges, there are so many, table 8.1 in the report is a listing of some of the programs and some of the sponsors of those programs that are putting out measure sets across the country right now. This happens to be a version of that table where the number of times a word is mentioned or an initiative is mentioned, you get a little bigger blow up in a cloud. The point is several. There is a growing number of initiatives with measure sets. Can there be an effort to look across them and find a common set that really meet the themes and the needs that we describe? Most importantly, frankly, from clinicians' point of view often is the burden. Every one of these initiatives somehow translates into time, cost, and difficulty in reporting and generating the measure results. And so there's a fantastic opportunity. The IOM has all the right attributes to pull together the people and examine where the opportunity is for a common set of measures. There was a lot of work spent on exploring those initiatives and then asking the participants in the workshop, can you put together the beginnings, a straw man, a skeleton of a framework for coming to common measures? And so the report discusses this, the workshop summary discusses this, and thinking about population health, healthcare, and cost, there was the ability to core out the sense of a set of potential metric categories you see on this list. And then the workshop summary actually lists some example metrics that the group was able to come to agreement around. It's the beginnings of an effort, and it really fuels that optimism and the interest. It is possible to do that. So measuring current health, but also the contributors, the predictors of risk and future health. So important. Healthcare needs to be patient-centered, effective, needs to measure safety, value and efficiency, coordination and communication. In cost, there's of course the emphasis on resource use, expenditures, utilization, and affordability. And I want to point out a theme that emerged, and this is an example of why these efforts are so important. Equity and variation need to be cross-cutting across all of those categories. And this is a framework, and then from this framework, groups explored potential candidate metrics. So the beginnings of an effort, and again, it was an awfully exciting process. Some of the key characteristics that came out as important for common measures, again, minimize the overall measurement burden. This was repeated. Try and utilize data that is captured by people going to work every day, just the routine work that people do in their electronic medical record systems, in their administrative systems, in claims systems, in all types of systems that are capturing data. If there was a guiding roadmap, a core set of measures, these systems would be set up and configured to capture the elements that are necessary to populate the measures. So utilize data that people capture going to work every day. You need the specifications that assure consistency across settings so we can really look at variation, look at value, look at opportunity. Use existing measures where possible. This was important to everybody. And if you saw the cloud diagrams, there is no shortage of measures, and there probably is great opportunity to put together some actually interesting composite measures, things that are meaningful and really can be used commonly across the country. Measures, of course, should be meaningful, as we said before, and there was discussion about the need for composite measures that combine some of our traditionally segregated data sources and really help us look at value. Most importantly, these came through, the measures need to be actionable. We need to be able to generate benchmarks, and they need to be things that teams, that people can respond to and improve their operations. Here's some of the examples of what was meant by actionable that came out of the discussions in the workshop. Certainly, the core measures need to be able to be used for quality improvement across settings, across organizations, across regions, so that we really have comparative look at variation. They need to be used to guide services for individuals and populations across settings, organizations, and importantly, disciplines. Where teams come together in initiatives that are springing up around the country, people that traditionally didn't work together, if there's a common measure they're all working toward, you have a shared interest. And that's very important, to create shared interest with common measures. They should be able to be used for payment and purchasing, reporting and transparency, and ideally for policy and regulation, and of course for scientific and clinical research. All the measures that should come in a common set should ideally support all these activities. There was a lot of discussion about challenges, and there was a tremendous amount of discussion. There's a lot of different challenges that come up. This is only a few, but it's some of the ones that stuck out. Certainly defining populations, and there's always the tendency to get so tight and narrow on criteria and the definition of populations that you actually segregate interests by doing that. Some people are interested in a measure, others aren't. Question is, can you broaden for a common set? Doesn't mean that's all you're going to measure, but for a common set, can you broaden the definition of the population so that it's relevant in maybe even to the general population? As Peter mentioned, leadership. It's so important to have leadership that can drive a culture of transparency and accountability, and that is going to be something that's critical. The value case for common measures, and I'll highlight one example of that in a few minutes, but again, the investment that's going into electronic technology, the digital infrastructure, how much of that that's being spent now would need to be remediated if we didn't have a common set of measures to build against? How much are we going to have to go back and redo? As was mentioned, it's not just about the measures and measure results. As Peter mentioned, the knowledge management. What do you do with the information? The collaboratives, the learning forums, the coaching, the facilitation that goes into using information generated out of common measures to drive improvement, to drive change. That's a key piece of this and has to be part of the implementation strategy. Ideally, measures that are useful at all levels. So something that's measured for an individual as they're routinely receiving health services. Can it be rolled up to look at the population within a setting and then across organizations, across regions? Can you roll up and down with a good common measure? And maybe most importantly, overcoming the tyranny of the now. That we're doing what we're doing, there's so much momentum. Can we undo, can we open up the opportunity to look across these initiatives and really move toward common metrics that will let us have a continuously learning health systems? So I want to use just for a minute here to give you one example of how, at least for us, common measures are so important into building the digital infrastructure and the learning health system. And this is going on, as Peter mentioned, all over the country, in states, in organizations, in programs. Similar efforts are underway. The roadmap. If you have a core set of measures that are actionable and important for multiple purposes, as we talked about, from that you can extract what are the key data elements we need to capture to measure those measures. What are the key data elements? And use that measure set and the data element set to actually build your digital infrastructure, to configure the EMR templates that capture the elements, to configure the administrative systems, to configure the way vaccine information is captured. You can use those core data elements to configure the systems that are being set up and invested in all over the country, including the interfaces and the exchange networks that are being built, and very importantly, the data intermediaries. There are data repositories, data intermediaries being set up in all types of programs around the country. If they were based on common elements and core measures, that would feed back and people would configure the systems that populate them. Without that, we're going to have to go back and redo this as we move on in the future. Once you set up and configure the digital infrastructure, then you test it. And you look at the end-to-end data quality. You see what you have in there. And this is where you really have an opportunity back at the source systems, back at the providers, the clinics, the hospitals, to improve the way data is captured and the way it's used. When you start transmitting data through these networks and you aggregate it and you count it, it's amazing what shows up. And I'll give you just an example of what that looks like in our setting. But it's that evaluation, it's the data quality that will lead to the trust that common measures can be used to improve all the services and the systems. And finally, once you know the data quality, you develop a work plan. What are we going to do to go back to improve the data capture? What are we going to do to help improve the systems and the operations? This stream is what common measures can help drive. Without common measures, we're going to have difficulty achieving the vision of a digital infrastructure and certainly the ability for a learning health system. So one snippet of this, and this could apply many places in the country. In Vermont, we have a whole network of patient-centered medical homes, some hospital-affiliated, some FQHCs, some independents. They're setting up their electronic medical records. As they do that, we had developed a core set of measures, a core data dictionary, the configuration of EMR templates, the development of interfaces. We're working with practices and giving them support to help build against those core measures so they can transmit the common data elements in, moving that into a health information exchange and then into a central registry, a data intermediary, if you will. There are also teams in the communities that are working right into the registry, tobacco cessation counselors, health educators, all types of individuals, multidisciplinary teams that work with the people in these practices. You're beginning to aggregate and normalize data. Well, when we started looking at what's being fed out of the electronic medical records, it was completely dependent on the site and the source system as to the quality. Most of it couldn't be counted, most of it couldn't be normalized. It took going back and actually using the core measures to improve the systems. And that now has begun a proactive process in Vermont where before people actually feed into the health information exchange, you use the core measures to build that digital infrastructure. This type of build out, if you think about it, and we talk to states all over, it's going on all over the country. The investments in EMRs, the build out using core data elements to guide it would be one of the great value cases for a common set of measures if you think about what's being invested in this. These are some of the things that come up. Everybody focuses on the clinical data, on is the blood pressure right, body mass index. Those are important. But you know what really stands out if you don't have common measures to build against is you often can't have the very basic demographic information you need. Who's really the provider for this patient? Is that updated? Are patients really active and inactive at a site? Who's deceased? Can you really even begin panel management, population management? Can you really begin comparative measurement without the very basic demographic information? This is the type of work, if you have common measures, people will go back and make sure that this type of information is appropriate linked to their clinical information. So just emphasize, this is not unique to Vermont. This is going on all over the country, and a common set of measures would help guide this investment and this build out. And that's when you have that high quality data, that's when you can really begin to pull comparative reports. Let providers see how their populations look compared to others. Use outreach reports to bring people in who didn't have vaccines or who needed services. But this type of reporting isn't trusted until the data quality is right, and it's the common measures that let you build the system to get that data quality right. So that's the key. And with that, I just really want to close out with this idea. If the work of the IOM and the others involved can really come to fruition with a common set of measures, doesn't mean that's all you're going to measure, but these things stand out across the country, and financial incentives are linked to measuring, tracking, the exchange, the aggregation, and really meaningful use of these things. If financial incentives are linked to that, we will move a long way toward a digital infrastructure and a learning health system in America. And so that's the challenge, and I want to thank the IOM for taking this on and Peter for supporting it. Thank you.